Good evening, and thank you very much for coming. We're going to be presenting a panel forum tonight on healthcare reform. I've already had people asking me, where is our thundering crowd of protesters? I'm glad they didn't come tonight. There's been a lot of yelling about this issue. And one of the things that I thought, and this was even before Claire McCaskill came to our campus, is that we have a lot of expertise available in our area that can talk about these issues. There are some very big, very serious issues here. And there's a lot of facts that really haven't been brought out. And so I'm going to present a few things for you, and then I've got a panel that's going to be addressing a number of questions. I think there's a lot of really good data to share with you. There will be an opportunity at the end of the program for everybody to ask questions. As I explained earlier, this will be broadcast on JCTV. So, you know, you can make a star of yourself, right? No. But let me give you some very basic facts. And if some of my numbers up here are a little off kilter, these are the latest numbers I could get my hands on. They are sometimes drawn from different years' data, which is why they won't match exactly. But the basic facts I'm going to present you with are fundamentally true. The first thing is that if you take a map, this is from the World Health Organization, and you try to show how much countries spend on health care, the United States is way off here all by ourselves. We are completely off the meter. We get our very own color to try to describe how much we consume. And right now, of our gross domestic product, that is the economic activity in America, 16.6% of it is in the healthcare field. Nobody spends that much on healthcare. Again, this is not necessarily an awful thing, but it is a very important fact. This is from a slightly different year's data. It's just 2006 instead of 2008, but it gives you in a bar graph form the way that we compare to other countries. And the average for the countries is 8.9% of their economy is on health care. I don't know why Canada decided it gets to be sitting here by itself, but the United States is, again, off the meter as far as the amount that we spend on health care goes. This fact really stunned me when I first encountered it, because I've taught this. I'm a professor of philosophy. I've taught medical ethics for a long time, and I keep having to recalibrate all my data. We are up to a point now where we consume nearly $8,000 a head on health care. This chart is estimating that by the year 2015, we're going to be up to, what is it, $11,684 per person. And again, these become fundamental facts that we're going to have to be thinking about. One of the things I heard at the Claire McCaskill speech, and one of the things that came out there, she was saying, if you want government out of healthcare, you've got to recognize it's already in healthcare. This is not a new idea. And in fact, right now, our government spends more on healthcare than any other government does as part of its share of its overall budget. Again, the percentage down here, government spending on healthcare is a percentage of government spending. So the United States already spends a fortune on, or a very large amount of money on healthcare through major programs like Medicare, Medicaid, veterans benefits, government employee retirement, and so forth. If you look just at Medicare and Medicaid in the federal budget, last year, from fiscal year 7 to fiscal year 8, these are the last years we have real numbers for, the growth for federal spending at that level for health care went up by $30 billion. And if $30 billion is just hard to put in context, understand that the entire NASA budget is $17 billion. And so the year-to-year growth, and if you really want to see it, I've got the whole thing here on the computer ready to show you, but the numbers get kind of dry. The growth in the amount the government is spending at the state level and at the federal level for health care has been growing dramatically and faster really than anything else the government gets involved in. These are huge issues for people at the federal and at the state levels. Despite the fact that we do spend an awful lot on health care, we have, as you well know, a large number of uninsured. We'll be talking about that. And this is just talking about where people get their health care from. For most people, 60% of the population, they get their health care because they work at a place that provides them with health care insurance. Medicare and Medicaid cover what, 27%? People who just go out and buy their own health care, 9%. People who get it through the military, 4%. And so by this particular chart, 16% are without health care, and we'll be talking about that issue. This is really interesting. If you go to the Blue Cross Blue Shield website, you'll be able to see this. There's no really good way for me to print this out for you. But this I found, again, very, very interesting. Where does the money come from that we use for health care? The biggest chunk is from private insurance, but you look here at Medicaid, Medicare, S-CHIP. Those are the largest two sources. We've got other public spending on it, other private, and then 12% of our healthcare expenditures are out of pocket. So you've got basically equal portions here of money that's coming from individuals and money that comes from the government, the rest covered by things like private expenses. What do we spend our money on? Hospital care, physician and clinic services, prescription drugs are 10%, and so forth. You get to see what the breakdown on that looks like. Again, if you go to the Blue Cross Blue Shield website, they have this data available, and it's in the most usable format that I've been able to find. Again, these are just some numbers. I'm just trying to give you a sense of context. The cost of healthcare in America is higher than anywhere else in the world. Why? And again, this is where everybody wants to find a bad guy. But there's an awful lot of reasons for this. Some of them are really good. And that's one of those things I don't ever want to ignore. Part of it is that there is overall inflationary effect. Anytime something causes the cost of food or energy to go up, it's going to affect the cost of health care. A big one in the United States is that we tend to stay on the cutting edge of new technologies. We want to have those MRI machines in our hospitals. Those cost millions of dollars. Cost shifting. I'm not sure if that's a term you've seen before in this discussion. That means because some people can't pay for their health care, the bill gets passed on to other folks. And so the bill that we receive as consumers is not necessarily accurate in the sense that it may be actually trying to cover up the costs that are covered by other individuals who aren't paying their full weight. There are complaints about administrative costs in America. One of the things that was discussed by the president this last week was the issue of lawsuits. That's typically not an area where the Democrats want to talk, but one where the Republicans want to talk. If you hold up a mirror, you'll see some of the sadder reasons. A lot of this is lifestyle. One of the things that actually dramatically affects the life expectancy of an American is the fact that we drive everywhere. Right? You live in the St. Louis area, you're used to driving 30 minutes to get to just about anything. But you put that many miles on the road and you put yourself at risk for all kinds of, if not fatal injuries, the injuries that will come from automobile accidents. Our diets, of course, are catastrophic in this country. One of the little factoids I heard more recently that really amused me was the idea that back in the 60s, we encouraged sugar. Sugar was good. Sugar was something to be proud of. Fat was wonderful. But we now consume, even though we're ashamed of fat and sugar in the diet, we consume more than we did per capita back in the 60s, when we were proud of it. We're living longer. This raises the cost of health care. Okay, again, anybody want to veto that? Ooh, you know, let's start shutting that down. One of the reasons people get into health care, at least in some parts of it, you make very good money in it. And at the college here, we try to get people into healthcare fields because there's steady employment and decent paychecks for relatively lower levels of education. With a 2-year nursing degree here, you can make a really nice living for yourself. Cadillac consumer demands. I put the question here, what's an open ward? Helen, when's the last time we had an open ward here in Jefferson? You know what I mean by that, of course. Anytime you've been at Jefferson Regional? Right? What did I have? I was in the hospital this weekend. I had my own room. That was nice. Look at the photographs from the 50s. What did we have? We had these huge bays, bed after bed after bed, and everybody just getting taken care of like that. That costs money. And we're very particular about all the creature comforts we get as healthcare consumers. And then one of the things that nobody's in favor of, inefficiencies and errors, those clearly do have a cost. I'm just throwing out some of the ideas here just to show you that there's a huge range of possible explanations and probably truth to every last one of them. Yes, it worked. Okay. that little introduction aside, I'd like to introduce your panel. Jim Watson is going to be our first person up here. Again, they're mentioned on your green sheets. Jim Watson, yeah, just take your seat over there. That'd be great. Is professor of economics here. He's on his 31st year here at Jefferson College teaching economics. So you know he's a man who's found something that he loves to do. Our next panelist is going to be Donald Mitchell. He teaches psychology for us here. He's an adjunct instructor of psychology. This is his 3rd year at Jefferson College. And one of the reasons that he offered to be on this panel, one of the reasons I wanted him here is he's got 13 years of clinical experience in healthcare dealing with mental health issues and counseling. And this is its own area of concern within the question of healthcare reform. And then I've got a couple of individuals who do not come from the college who have very graciously offered to give us their Monday evenings here. The first is Dr. Lloyd Ford Jr. He is the CEO of, let me get this right, Jefferson Health System, which includes, among a whole bunch of other things, Jefferson Regional, which used to be, of course, Jefferson Memorial Hospital. And so, obviously, somebody who works in the field. And then kind of a last-minute addition, somebody said, oh, you've got to get Dr. Kimmy. He's so good. Dr. James Kimmy, he's the actually Chief Executive Officer of Missouri Foundation for Health, which is the largest organization in the St. Louis area that works with the uninsured. Is that a fair description? Okay, because I just got to meet him this evening. So I'm excited about the quality of the individuals that we have here. There's a series of prepared questions. I've already given them a heads up about what these questions will be. And so I'm going to be posing them to the panel, and they get to pass around the microphone. But I'm just going to have one person get the ball rolling on these questions, and then I'm going to let other individuals chime in as they find them interesting. So, Dr. Kimmy, I'm just going to start. Ooh, see how well that works? Oh, sorry, let me grab it back. You can ask okay, well, I think one of the puzzles that we have had with the talk of healthcare reform lately is what is it that we're exactly trying to address? The question doesn't seem to be sitting still very well. So the question I want our panel to first start with is what's wrong with U.S. healthcare today?
Well, the problem of providing satisfactory medical services to all the people in the United States at costs they can meet is a pressing one. At the present time, many persons do not receive service which is adequate, either in quality or quantity, and the costs of service are inequitably distributed. The results a tremendous amount of preventable physical pain, mental anguish, needless deaths, economic inefficiency, and social waste. Furthermore, these conditions are largely unnecessary. The United States has the economic resources, the organizing ability, and the technical expertise to solve this problem. That's a quote. Does that kind of catch what you think's with the system now? That's from the Committee on Costs of Medical Care. And if you haven't seen it in the news, it's because it was released in October of 1932. And the saddest part of talking about healthcare reform now is that we've had this problem in this country for decades. We're going on, what would it be, 77 years since that report was put out, and you can still use the same description to describe the situation in American healthcare today, and that's a travesty. And it's one that cries out for solution. Now, we've tried, and I'll take just another minute, and I'll pass this on. This report was prepared for President Roosevelt. And when his staff came up with the Social Security Act in 1934 and 1935, when it was passed, healthcare was a part of the discussion at the beginning, and the president insisted it be taken out because he thought that the opposition from various special interest groups would kill the whole Social Security Act. And so he took it out. Social Security passed. We now have it, and it's been in place for a long time, and it seems to be working reasonably well. Harry Truman tried in 1945. You might be surprised, Richard Nixon tried in 1971. Bill Clinton tried in 1994. So we've tried and tried and tried to do something about this intractable problem in American society without success. You know, our moderator said, point no fingers. I think it's not necessary because there's enough blame to go around. Every interest group involved in this bears part of the responsibility, as does every consumer of health services, bears part of this responsibility. So we've got a long way to go. We've come along. We've tried for a long time. It's time to stop fooling around and fix this problem. And I think the opportunity now, I used to say back in 1970, time that Kennedy had a bill, I used to say in 5 years we'll have national health insurance. 1971, I said in 5 years we'll have national health insurance. 1972, I quit saying that. And, you know, I'd like to say in 5 months we'll have some kind of health care reform that works to solve some of the problems of 1932. Anyone else?
One of the problems that I think is politics, as you alluded to, and it isn't today. A lot of people are saying it's the problem of the Republicans are obstructing and they don't want the plan, but there have been times where the Democrats have done that. For instance, Teddy Kennedy, who just passed away, said that the biggest vote that he regretted voting against was President Nixon, the Republicans, his health care plan that he said would have been a good plan, and but he voted against it. My political hero, Senator Eugene McCarthy, who ran for the presidency, a Democrat, but said one of the things he regretted is that in 1956, Senator Taft, who was known as Mr. Republican, Mr. Conservative, in 1956 wanted health care, now not total, but for catastrophic health care, and it was voted down because the Democrats didn't want to give the Republicans a chance to get the credit for it. So it goes back and forth. And then also the lobbying and the money that goes into lobbying is just huge, and that's a basic problem. So politics and lobbying and special interests have a lot to do with it.
Coming from the side of providing health care, there's a lot of major problems with our health care system now. A lot of good things, a lot of ways things are delivered, and bringing politics in the game is a perfect example. Lobbying, I go to Washington, D.C. many times, and it's almost devastating to see some of the companies that have large amounts of money lobbying against healthcare reform at this moment. I believe that there should be some type of health reform and getting out there what's wrong right now, presently, between, for example, at our facility now, we provide the government provides 68% of the health care for our county right now between Medicare and Medicaid. The problem that has came is since all the manufacturing business and that has now left the United States to go to places that have lower salaries and everything, what has happened is now healthcare has been exploited. And it's continuing to be exploited. Prices are rising. A lot of times people will blame the hospitals and the physicians for the large amounts of monies that we charge. But the issue is we got to cover costs. And we got to continue raising costs. I know when you get your bill, it's not a pleasant sight to see the amount of money that is on a lot of those different charges. What we need to do is other things wrong with the U.S. healthcare system is everybody believes competition will lower costs. They started this a number of years ago. But what has happened is now everybody has an imaging center, everybody has a surgical center, and everybody has a hospital on every corner. Prices do not get lower when another hospital is put on a corner. Actually, the prices go up because what happens, we all get paid a lot of the same amount of money. You know, with Medicare, if there's a certain DRG, we get paid that amount of money. So what happens is now these other centers have to create volume. So what happens is then they get defensive, or then you start going for additional services, and then the cost keeps rising. They got to pay their staff and everything else. So the next thing you know, instead of lowering costs are rising because everybody has to, you know, pay the bills and everything else. So we got a long way to go when it comes to believing in what we want to do.
Okay. We're going to have some questions at the end. Did you want the word DRG explained?
No, I wondered what would be an example of a large company that is lobbying against healthcare reform.
I won't. Right now, when I go to Washington, D.C., first of all, the insurance companies, they absolutely do not want health reform. For example, United Healthcare just put out close to $300 million in lobbying efforts against a health reform in Washington, D.C. And when you look at the overall picture, you got the pharmaceutical companies, you got the insurance companies, you have the hospitals, and then you have the physicians. And basically, the hospitals and the physicians are a small pea in a large pod. The insurance companies, you know, for example, United Healthcare, and I'm not picking on them, but they made close to $93 billion in profit last year. So they have a lot of that money. Same thing with the pharmaceutical companies when it comes in. So really, all of us together have to work as a whole to change this system, and that's some of the problem when you get into politics. It's in a lot of different things. Whoever has the most money can usually get their way, and that's usually where they get swayed a little bit on there. And we do as much as we can on the hospital side at Washington, D.C. to try to get it. And we truly believe there should be some type of health reform. But what happens in the long run is they go down the list, and the hospitals and the physicians are the ones that end up getting it taken out of their, what I call it, taken out of our shorts, and then we got to continually look at ways of providing high-quality health care at a very low cost.
I love this panel. We've brought in politics, which I didn't know we were going to bring in. We've been very specific about the fact that both parties have opposed health reform at one point or another in the past, which we so often lose sight of, and we've actually named some of the devils, despite the fact the moderator didn't want us to. The insurance industry is spending $1.5 million a week on lobbying, and have been all year long. You had a recent demonstration in this facility, or at this campus, which got national coverage when Senator McCaskill was here. That was not a spontaneous demonstration. Those demonstrations have been planned for almost a year and a half. From the time that Mr. Obama became a candidate and started talking about health care reform, the health insurance industry has been putting money in, and some of the political interests we've been talking about, have been putting money into messaging. What's the message? Death committees. Now, there's a message that grabs people. And unfortunately, you know, Mark Twain said, why does the devil get all the best songs, talking about hymns? And, you know, why does the opposition to healthcare reform get all the best slogans? But they sure have them, and they're things that really resonate with a lot of people. Socialized medicine. You know, I haven't heard that one seriously since about 1960, but it's come back and it's being used. Putting that kind of fog up around this serves the interests of the people who oppose, and the industry, the organizations that oppose it very well. And the point I want to make before I'll let you pass it on to another question is, let's go back to my context, 1935, 1945, 1971, and so forth. In 1935, when Roosevelt scrapped this, it was because he feared reaction from the one group that at that point in history was making money from healthcare, physicians. They were really the ones that he was afraid of. Harry Truman in 45, he found out that was right. And AMA spent more in 1945 to lobby against Harry Truman's bill than had ever been spent in lobbying in this country in the past. But what's happened since 1945? In 1945, we began an experiment very different from other industrialized countries in which we are using employment-based health insurance. What's grown up as a result of employment-based health insurance? One of the biggest industries in the country, the health insurance industry, you see. That wasn't there in 1945, it was all the docs. But as we've gone on, it's become more and more economically invested in the status quo. And so what we're seeing now is tremendous resistance in changing the status quo, or support for changing the status quo as little as possible. And that's really the battle that's going on, I think.
I just want to bring back is when I mentioned the insurance companies, and we all have a part in this, so I'm not really signaling on anybody as a whole. I'm kind of listening to things that I get in. Really put everything in a nutshell with healthcare is people in our society as a whole has not made healthcare a priority to themselves. That's probably one of our biggest issues. And now we're dealing with this when it comes to lifestyles, everything else. So, you know, we can blame as many people as we want, and I can point fingers at when, you know, I get my reimbursements cut and I got to do more things. But we're all in this as a whole, and I think that's where we've lost focus in, and I think that's where our government has lost focus in as a whole, is they want to solve this on their own, and they're not asking the right people to be involved to come up with the right solutions, because I believe we got some very high quality people that are running healthcare systems in the United States. And we can come up with a good solution that's going to be, as a whole for everybody, good, but they don't want to listen. And that's unfortunate with our society right now, and that's not a blame of anybody, that's just the way we've kind of made it right now, and somehow we got to get back to it.
Okay, when you get the microphone, okay, I'm gonna try to keep this rolling. Sure. Because I've got several different questions that I wanted to pose to the panel. After asking what was wrong with healthcare in America today, I did not want to, again, and I've already sort of said this, I don't want to ignore the fact that we have an awful lot to be proud of. So maybe kind of quickly, if you wanted to explain what it is you think that we need to definitely hold on to and be proud of in the healthcare system that we have right now.
The reason I'm in healthcare is because we can save an individual with the drop of a dime. Anybody right now, anybody here, falls over with a heart attack at this moment, we can have you into our cath lab and a stent put into place in less than 60 minutes. That's incredible. Back a number of years ago, if you keeled over with chest pains, you probably were going to die. That's what we're proud of here. We can save anybody at any time in a very quick period of time. Now, what that has done is it's evolved into more cost. But what I'm proud of right now is everything we do to be able to take care of people throughout the United States. We have the best health care. A lot of times people will say that, other countries have better health care in a way. For example, I'm going to Africa here this weekend. I'm a little concerned. I hope nothing happens to me because, as you can see, their statistics up there, they do not have a system even comparable to us. You've also heard about medical tourism, where you can send people over across into other countries for cheaper health care. The problem is what happens when you come back and you have complications. We are a country that has very high technology where, you walk into the ER, we can save you. And that's what we need to be proud of. We have cutting edge technology. Every piece of device for the healthcare industry is demoed in the United States first. Now, it's made overseas a lot of times, but we're the first country to usually involve that. We have equipment here that nobody else. We actually will sell our 15-year-old equipment to these other countries. For example, that we just had a recent CT scanner that we sold to another, that will go to a third world country that is 15 years old. So what we got to be proud of is that when we get a disease, most other countries are not going to be able to fix us. And that has contributed a little bit to our problems in healthcare, is because people are living a lot longer. We might have grandma that lives till 98 years old. You can put a knee or a hip replacement in, and they'll live another 10 years. So we've kind of created some of our own issues with our technology and the way we can continually develop new cutting-edge technology that will make people well very quick. I mean, for example, years ago, cancer, if you were notified you had cancer, you pretty much were going to die. Where today, we can fight most cancers and actually put them in remission, that you can sometimes live the rest of your life or have, 10, 15, 20, even 30 years more of your life. That didn't happen years ago. In most other countries, when that happens, you're probably going to die within a very short period of time. So that's what we need to be proud of here. We get beat down a lot on our health care, but overall, we provide the best possible care anywhere in the world.
I wanted to just make a statement on the positive of, what do we have to be proud of?
You have to hold that close to you.
What do we have to be proud of in the delivery of U.S. health care? And mainly because of research, is that, as Dr. Porter, is that we were saying we're on the cutting edge of a lot of things as far as the treatment in health care. And also, when you're looking at, something else that we can look at and be very proud about, is that, a person living to be 80 and 85, you look at the quality of life. And that's because of the health care that, the great doctors and surgeons, that will allow us to get that quality of care, that once that a person some diseases, whatever they were. I can't, none coming off the top of my head. Remember, I'm in mental health. Is that some years ago that people really had to live with and suffer with, even though you were living up to be 85 or 90 and 95. And now, because of, you know, the pharmaceuticals and what the doctors can do, and possibly because of what the healthcare insurance have allowed them to do to some degree, is that the quality leading up to those years are much better. And I don't know about anyone else. It doesn't mean a whole lot to me, and I'm in my mid-40s now, is that I get to be in my mid-80s if my quality of life is not that good. I mean, that's what's very important to me.
From what I've read, now I don't know how accurate it all is, but from the World Health Organization, it doesn't exactly rank us as number one. Matter of fact, we're sort of in the 30s or 40s. 37th, if you compare it. So, no, 37th with regard to quality of health care. Now, measuring quality might be a little difficult, but some things that are really easy to measure are things like how long you live, and we aren't even close to being in the top 10 or 20 in that. I don't know exact figure, but we're like 40th or 50th. And infant mortality is another thing that we don't. We're in the 30s. There are some countries like Morocco and other countries like that do better than us. So a lot of people say that we have the best health care in the world, but the World Health Organization at least doesn't agree with that.
I think the problem is that we have islands of excellence, really top-notch. St. Louis, Jefferson County, you've got an island of excellence separated by oceans of inadequate service and questionable quality. You can get your heart, you can get your stent in this county in 60 minutes, but try living in rural Missouri and getting to that. Try living in rural Wyoming or anywhere else. We have a tremendous problem, although we have we have high quality services if you can get to them financially, geographically, or other ways. But if you don't have access, you can live next to BJC Hospital, and this happens. There are people living next to BJC Hospital who can't use it because they don't have any money. And they can go to BJ when they're really sick, and the hospital has to treat them. They come to the emergency room, and Tala says they have to be stabilized. But by the time they come, they could have been treated much earlier if we had a system of primary care that was adequate to the population. Our biggest problem is not technology. Our biggest problem is organization and how we organize the system and having the kinds of primary care providers, not just, you could say primary care physicians. It doesn't have to be a physician. Primary care nurses actually rate better with their patients than primary care physicians. Physicians' assistants can do a lot of things that they're not allowed to do under licensing laws. So we've said before, it's a complicated problem, and there are a lot of issues here, but if we don't get a primary care system in place that works for everybody, then all of this wonderful stuff that we've got in the medical centers is not going to solve the problem. We're dealing with the failures of prevention, but we'll come back to that.
Pass it down to Jim Watson. The next question is, we're going to have the chance at the end, because a lot of these will come back to other issues we're going to look at. From an economics point of view, we're dealing with explosive costs in healthcare. What is obvious as an economist looking at this explosive cost issue?
The administrative costs are really a problem. There was a 2003 St. Louis Post-Dispatch editorial that I like to use as an example. It pointed out that, and there was a doctors group, as a matter of fact, 8,000 doctors were making this argument, that in New England, it took Blue Cross more people to cover and administer to 2.5 million New Englanders than it took Canada to administer, in other words, keep up with the records and all that, of 27 million Canadians. This morning I talked to a student of mine who's from Germany, and he said in Germany they just have a card, and instead of filling out all the paperwork that you normally fill out, there's a chip in it, and all the information, including blood type and everything you need to know, is just scanned, and that's all they need to know. So that's something that we could really reduce a lot of costs, and there's upwards to 200 million or billion, billion, trillion, you know. Yeah, about a bunch of zeros. 200 billion at least in savings in just paperwork alone.
Okay, we're talking about containing health. We're talking about containing healthcare costs. I mean, there are a number of factors. The slide that you showed is that you know we're shifting costs, administrative costs, giving my friend a ride to work costs. I mean, and as crazy as that sounds, but you think about it, just in any other in every other industry, when the gas prices went up, actually so did the cost of food because of transportation of it. And the same thing is going to happen, you know, with any other industry. And I'm not saying, you know, gasoline prices directly, but when equipment is shifted from one place to another and is shipped, there's an additional cost. I ran a private practice for 14 years, and there were a certain amount of costs that were involved because I had an office manager, I had a person, a secretary, and we also had an RN in the office. Well, when the actual cost, and we were dealing with HMOs sometimes, they would give, I guess, less for a session in psychology, or less for a session in therapy, is that, you know, therein lies when we would shift the cost somewhere, because people that had alliance programs is that they would pay up to $75 during that time, is that, you know, I'm just being honest. You know, sometimes as opposed to charging $68, we would charge $70 and get the $2 back that way. I mean, that's how it is. I mean, I'm not saying that that's the way to do things, but it's somewhat like, I guess, Reaganomics of the trickle-down theory, is that, you know, when it starts trickle down, you know, everybody's going to do their part in. And I know from having been on staff at a hospital and dealing with inpatients, the importance sometimes was filling beds. So you're going to have those things. There are a number of things we can do to, you know, contain costs. And that is that, you know, we say we're not going to pass it on, we're doing this pro bono, then do it pro bono. Don't pass it on to the next person.
Well, talking a little bit about passing on the pro bono, actually cost shifting has kind of been eliminated to a degree in a lot of different aspects. I mean, there is a function of charges that are factored in for expense, as with any type of bad debt in any industry. But what we have to do to contain costs, I see three big areas. First of all, we really got to teach palliative care at the end of life. I see that on a daily basis. 80% of Medicare costs are spent in your last 6 months of life. And I see it on a daily basis where families are not educated, or they don't want to really hear that you're going to lose a loved one at the end of life. So there's times that we are doing procedures that will not enhance the quality of life at all for that patient. And I know we took President Obama took a big hit about this death panel he called about. And believe me, I've read this whole health care bill just about, and I will back this one on it, is the palliative care. There was a palliative care issue in there that said that they were going to pay a palliative care rate for somebody to come in and speak to the family about the end of life. It wasn't a death panel. I mean, I had somebody last week that we continually talk to the family about, that, you know, your loved one, there's no more life here, and they still wanted everything done. For example, that will cost us probably about $150,000 for what we had to do last week. And that's some of the big issues that we can look at containing costs. I know a lot of people don't want to take that look at the end of life, but, you know, we really have to look at that. And it's not rationing care as a whole, but being looking at what is in the best interest of this patient. I know I have my advanced directives, and if I can't efficiently have a quality of life, I don't want to be here. And that's what we really got to look at. Other things are, containing healthcare costs are, driving, continually working and driving cost and waste in the healthcare. Healthcare years before, and it's been hard. I'm kind of the new breed of CEOs. I've been brought up in a different way that we're always trying to reduce costs in a lot of different ways, but also have the highest quality. And that's why Jefferson it's public knowledge here, will be coming out in the next week, that we've been noted as a top 100 hospital for both quality and the value that we provide for our cost. We are the lowest cost provider in the whole St. Louis region, and we continually do that. If you were to go to another hospital for the same procedure and come to Jefferson, it's probably between 2 and 3 times. The reason we're doing that is we're continually looking at our costs, because we know it's on everybody's mind. And if you don't have health care, we sit here and we try to work with you, so it can be paid for and all that. But we also got to look at, we're based on widgets. Unfortunately, the healthcare industry is widgets. Doctors, it's how many patients you can see. It doesn't matter if you fix them or not, it's how many you see. And we got to change that. We got to look at, there are processes out there that haven't really been pushed forward because the government hasn't put any dollars to it when it comes to it about quality of care. I mean, it shouldn't be a matter of, right now we have physicians and I have contracts with them, they got to see 45, 50 patients a day. It's not about if they got them cured or not. It's about how many patients they can see to be able to make that money from there. And, we got to continually work on those areas, base our healthcare system on quality instead of quantity. And that's the only way we're going to continue to be able to draw a cost out of healthcare and continue to keep it from rising any further.
Well, let's talk about costs for a minute. My favorite economist is Uwe Reinhardt from Princeton, who does say pithy things about this. And he said, the thing you need to remember from an economic perspective, that every dollar of healthcare cost is a dollar of income to somebody. Every dollar is a dollar of income to somebody. The money doesn't just disappear, and he just made the point. It's a labor-intensive industry. If you're going to take out costs, you've got to take it out somewhere, and you take it out on the labor side. So as long as every dollar of cost is a dollar of income to somebody, it's much safer for politicians to say, costs are out of control, we've got to fix it. They're not dealing with the real problem. The real problem is equally on the income side. It's a cost problem. If it's a cost problem, it's an income problem. And that is the kind of the dirty little secret of economics we don't talk about very much, is taking costs out of the system means either reducing the personnel or reducing the compensation. Plain and simple. Now, there are organizations that have done that. You've got physicians under contract. There's a lot of talk now, and you're going to hear more of it, unfortunately, from my perspective, about healthcare co-ops. The public plan seems to be off the table, and everyone's talking about Senator Baucus is talking about substituting healthcare co-ops. A healthcare co-op can be defined really simply. It's an HMO. It happens to be owned by the people who are enrolled, but other than that, it's an HMO. And the healthcare co-ops that work in Seattle, Washington, and Minneapolis, that's it, too. The healthcare co-ops that work employ their physicians, pay them a salary, and own their hospitals. Now think about it. They are able to control income and therefore control cost. And so, in Seattle, the annual increase in premiums for group health is only 12.5% a year over the last 5 years. Only 12.5%? Well, Blue, who have most of the rest of the Seattle market, about 17%. So it is a saving, but costs are still going up in the co-ops. So, every time you think you've got a solution, the major cause of solutions, the major cause of problems is solutions. So every time you get a solution, take a look at the problems it's going to cause, because they're there.
Thank you. We're having a good time, but I do want to try to get through all these questions and give people here a chance to ask their own. A very specific one for Donald Mitchell has to do with resources for mental health treatment, and that's been actually a side discussion that's sometimes treated as separate from the overall question we have of healthcare.
The allotment for last year was $69 billion for mental health care in the U.S. I got that out of it was a book on healthcare statistics last week. What I've noticed is that a lot of times mental health care funding is the first to be cut, primarily because you're dealing with the abstract. You know, unless a person is having some problems at work, such as depression or anxiety, and they're not producing at their optimum level, you know, then the company will send them there. Well, you know, you don't necessarily have to have full-blown depression in order for your functioning to be, you know, at a lesser level or to need mental health care. But what I've noticed, and this was one of the reasons actually too, why I kind of cut back in private practice, was just that, because of the cutback in that area. It was a lot of times I was seeing people that really needed, you know, if it was a kid who had a problem with ADHD, or people with bipolar, which is, you know, I went to school an extra year during my master's program to get a specialty in that. What I would find is that when dealing with HMOs is that they were just saying, well, you know, what we would look at is that, well, you only need, you know, 3 sessions to, you know, get this person back functioning. Well, you know, sometimes that's not the case. You know, very few people are average, you know. You know, we either are above or below or whatever, and then if you are above, then you're going to say, well, if everyone says that they're above average, then the average, you know, raises. And if they're below, then it falls somewhat. But when we're talking about the funding of mental health, is that, like I said, it's one of the first to be cut, primarily because it's so abstract. And I understand the insurance companies doing that because it's really hard to measure change, whereas in a physical ailment or something is that you can measure it. But, you know, how do you say, well, the person's doing 70% better, they're feeling 70% better today, or their depression is 60% better? It's really hard to measure, even when giving, you know, various inventories. So I guess, you know, the funding with that is that I go back and forth every day on, well, should it be cut, should it not be cut? And I still don't have an answer, and I'm a practitioner.
Does anyone have anything to add on that particular question? Okay. Obviously, one of the big concerns.
Obviously, one of the big concerns that's been discussed as one of the core issues is the question of the uninsured, and of course, we've got a local expert on that. Actually, I didn't pose this precisely, but there are all kinds of estimates that I've seen. I think the number that was thrown out for about the last month was 47 million. I've seen some people try to bring the number, pare it down to about 5 million, if you take away people who, say, could afford it on their own and so forth. So could you talk about the sort of the magnitude of the issue of the uninsured?
Yeah, the Census Bureau number just came out as 46.8 million, up substantially from the last number that came out. Projections are that if we don't change anything, it'll bounce to 50 million next year, maybe even earlier. And it's a very real problem. The uninsured get sicker, they die quicker than the insured. 18,000 people, that's divide it down, 18,000 a year die because of uninsurance, nothing else. I mean, it's the contributing cause for 18,000 deaths a year. So it's a serious problem. Now, you know, you're the philosopher, and if you were on the panel, I'd say let's talk about the philosophical question about how many uninsured is tolerable for a free society that prides itself on being the leader in the world. 47 million? 40 million? 30? 20? 10? None. It is unacceptable to have uninsured people in a country this rich and with the experience that we've had. And the other thing about the uninsured, they're increasing rapidly now because of because of cutbacks and people being laid off and so forth. They get through that COBRA, and the COBRA is helpful, but it's time-limited COBRA, and it's also financially limited in how much the government will reimburse. Once you're off COBRA, you are now one of the uninsured. Everyone is a paycheck away from being uninsured in this country. Everyone is a paycheck away from being uninsured. There's something wrong with that picture. If you change employment, I mean, there are people who stay in a job they don't want, don't like, because they can keep the insurance, and they know if they leave, they may become uninsured because they aren't able to get something at their new employer because of waiting periods, or the new employer doesn't provide insurance. So it's a gigantic problem. It's not overblown. But I think that the biggest problem is not the number, it's the fact that we allow any.
We are the only modern industrialized country not to have total health care. I oftentimes show to my students the G7 nations. Actually, 8 nations, including Russia, meet every year. The heads of state meet in June. And the United States is the only one not to have universal coverage.
Okay, okay. One of the chief reasons that we have the lower life expectancy in comparison to other developed countries is not simply that we don't have health care, but that Americans make absolutely unbelievably bad health care choices. Everybody knows this. It's, I think, considered to be about 40% relevant to our life expectancy in this country. Attempts to fix this have not been particularly appetizing, but I wanted to throw to the panel. Is there anything that realistically, practically can be done to be working on some of these lifestyle issues where behavior choices drive so much of the healthcare costs?
Actually, yes, there is some, but it's hard getting into a little bit. Presently what I'm trying to do is I'm going out to all the businesses within Jefferson County in our market area. We have a wellness program, and actually we're going to start instituting that within our health system here, is that the healthier you get, the less you're going to pay into your premiums on a monthly basis. Right now, the state laws, I can't say if you don't smoke that you only pay this. What I can do is I can discount that from what we pay for premiums when it comes to it. And for example, I'll just give you cost right now for a family plan for our hospital. For a full family plan is about $15,700 per year. Where the employee picks up about $2,500 of that one. So you can see I'm picking up about 90% of those costs. So I have a little bit of leeway in here, but what you get into is our society says that I don't have the right to tell you to be healthy at the workplace, and I'll bring up a perfect example of smoking. I'm very much against smoking, and it's nothing against anybody in here if you do smoke. My dad smoked for 45 years. When my dad did have a heart issue 7 years ago because of the 47 years of smoking. Luckily, we had the ER caught it. He had a stent placed in, and he's in good health. But due to that smoking, that was a cost to our healthcare society as a whole. The other, a lot of other different things is, like I said, we have now went totally campus-free smoking for all of our employees and patients. Now, yeah, I do hear stories. We're driving around, and there's a patient out with their IV pole out in the parking lot smoking. Yes, that happens. It's very hard to capture all these individuals and going in. But what we need is everybody to work together to change these lifestyles. And one thing is physicians. The physicians in our meetings will say that we totally are for not allowing patients to smoke, but when the patient yells and screams at them in the hospital room that they need to smoke, they say, well, just sneak out back and do it. So we need a whole change of philosophy for all of us. Same thing with eating. There's a lot of places that have went into having your body mass measured at a time, and if you get down to a certain weight, your health premiums are reduced. And I think that we need to do that overall as a whole society. The issues that we run into is that, like everybody, myself, I don't want to be told what to do. That's my personal life. I run into that with smoking. I have employees that have told me that I can't tell them what they can do and what they can't do. when it comes to smoking. And I bring the whole aspect back into is about drinking alcohol. Yeah, I don't allow drinking alcohol on campus, so why should I do smoking? And they say, well, smoking's a disease. I said, what about alcohol? Alcohol is a disease. So there's a lot of things that play together. Same thing with obesity, diabetes. And I think also we got to get into a lot more educational programs and bringing in more wellness to the workforce. So we're going to make a big push, at least for our Jefferson County businesses over the next year or two, that I'm going to make a focal point is trying to work with these industries to make their workforce even healthier so they can lower their healthcare costs and look to the hospitals as somebody that can help them control those costs when it comes to there. So there's a lot of things that we can do. It's just going to be a matter of how our society takes it as a whole, and don't take it as that what we're trying to tell them what to do.
Talking about lifestyles, I talked with a physician at BJC, and the person who was a cardiac specialist said that when patients who had been in there was prescribed exercise and to change their diet, that they had 63% less hospital visits, for that condition. And that was statistics as late as 2007. They don't have them in for 2008, but she did give me for 2007. A lot of our lifestyle, has a lot to do with our health. I grew up on a farm and ate green beans, peas, everything else out of a garden. And so consequently is that, I didn't feel sluggish and also the times that I ate those meals at. Breakfast was the biggest meal, and as you taper down the day, you're working at a farm, the meals would get smaller. So, consequently, so you wasn't going to sleep with, all that stuff in your body. You had the whole day to work it off. But we really don't, I feel that we don't exercise enough. I'm an exercise nut. I went to college on an athletic scholarship, and so I'm really into that. And plus, the other thing is fast food. I mean, let's look at what that stuff actually does to your body. And if we could just pull back from that, those are some of the things that we can actually do in lifestyle. And the other thing is stop wolfing food down. I lived in Europe for a couple of years, and it wasn't uncommon for lunchtime to be 2.5 hours, give you time to digest the food. A lot of places is that, the lifestyle, the job dictates that, you only get 30 minutes or maybe 45 minutes for lunch. So, wolfing it down isn't doing, your heart any good either. So, what we have to do is looking at changing some of the things that we can do to change our lifestyle and be healthier people.
Want to go to the next question? Or do we want to talk about lifestyle? Okay.
Yeah, I think that the points that been made about lifestyle are really good. I didn't bring any overheads or slides tonight, but I have some wonderful ones showing the McDonald's in the lobby of a children's hospital. I was recently in a well-known hospital in St. Louis at the breakfast time, and the entree was biscuits and gravy. Now, nothing goes to the coronaries faster than biscuits and gravy. I love biscuits and gravy, but we've got to go by example sometimes in the institutions, and you've cited some things. I don't know if you have a McDonald's. No, you don't have one. Okay. I was pretty sure you didn't, so I thought I was on pretty good ground. But I think that, Donald said that one of the first things go is mental health when there's trouble. Prevention goes first. Mental health goes second. And we don't invest enough to even support lifestyle changes. And as we go into the health reform, and this is sort of the last thing I was going to say tonight, but I'll say it now. Health reform, no matter what passes and what goes into effect, will fail in this country. And it'll fail for 3 reasons. 1, because we don't have the workforce for it to make it work. 2, because we're not committed to prevention. And if we don't commit to prevention, the same kinds of treatment of failures of prevention are going to continue and get worse. And 3rd, health literacy. Having people understand about their own health, which is fundamental to good preventive programs, but it's also fundamental to good utilization of the healthcare system. And as long as people, well-educated people, can't read their prescription or if the prescription says take 3 times a day, and they say, well, you know, maybe I'll take it at 10, 11, and 12, and then it's out of the way for the day. We do a lot in our society, in our medical side of things, that is very poor communication. And if we don't fix that, and prevention and workforce, then whatever you pass for health reform will ultimately fail.
2 more prepared questions, and then you get an opportunity. All right, we're doing better with time. I've been fascinated to see the demonization lately of international healthcare systems. Rather than approaching it as a set of trade-offs, and to say, well, if Canada spends 10% of their economy versus 17% in ours, how does that work? There's been fascinating demonization. So the question that we'll start at this end with is whether we have anything we could learn from other countries about healthcare provision.
Well, speaking of Canada, glad you brought that up. And this should really hit a nerve in Jefferson County. Recently, Chrysler, the plant in Fenton, one plant went to Mexico, one went to Canada. The one that went to Canada has almost exactly the same labor costs, raw material costs. The big difference was Canada has what they call a single-payer system, which we have with Medicare and the VA. And that made the difference, and that is, I would say, the main reason why that plant went from the United States, went from Fenton to Canada. Now,
Jim,
yes,
that Canada plant's $3 an hour higher.
I talked to a friend who said the top pay that they get on the line is $25, and it's equal. But thank you for backing me up there. In any case, talking about administrative costs that was brought in earlier, is that we have Medicare, and now Mike and I have talked about the differences in the percentages. But in any case, what I've heard, and numbers thrown out, is the administrative costs at Medicare. In other words, what it costs to administer the paperwork, and the rest of it goes to actual medical care, was 3.5%, whereas insurance companies, it's more like 30%. Now, I don't know if those numbers are exactly right, but I do know that insurance companies have, if you take a look at Forbes on their website, or in Google Forbes, you'll see that they give a list of CEO pay and executive pay, and one fellow, now if you include not only salaries but also stock benefits, one fellow who was heading an insurance company made over $60 million, and it's huge. Government employees don't get that kind of money. Also, lobbying, paying for lobbyists. One of the key senators on this determining the finance committee, and you said your favorite economist was, I forget who it was, but one economist that I've been listening to is Paul Krugman, and he said that take a random Senator Grassley from Iowa, who's one of the 6, and he said for one thing, there is no competition in Iowa. That there's one company that has 70% of the business, so there really isn't competition, and his top 4 campaign contributors are all from the healthcare industry. So that has a lot to do with it. Now, what other countries, as far as keeping costs down, what we're comparing is Canada with single payer versus ours, which is employer-based. The problem with employer-based is it adds to the cost. Ford now spends more in healthcare than it does for steel. So Ford is now interested in keeping the cost down. And one thing that we should be very conscious of, and that most Americans don't pay attention to, is we have been running trade deficits since 1976 to today. The last few years, it's been $700 billion a year. We are losing jobs steadily. Most economists won't say that because not all economists agree. As a matter of fact, they usually say if you stretched all the economists end to end, they couldn't stretch far enough to reach a conclusion. So I'm in that boat. But and I'm willing to listen to other ways of reducing that trade deficit, but that is a hemorrhage of jobs, and this example in Fenton is a perfect example of that.
Yeah, there are a lot of other ideas for that in other countries that we could look at we're never going to take the system from Sweden or the system from England or the system from anywhere, France, Germany, and make it our system. Whatever we do here, whatever reform looks like, it'll be uniquely ours. That doesn't mean we can't get some ideas. Right now, the highest rated from the standpoint of the patients health system in Europe is Denmark. And what did the Danes do? Well, first of all, it's not centrally managed. It's regionally, it's the equivalent of the state of our states runs the system. The federal government, the national government collects the taxes, returns in the local area, and the local area makes decisions about things like how much to invest in hospitals, how much to invest in physician services, and so forth. That's not unusual. What's unusual in Denmark is the health information system that they've built underneath this, underneath their health system. In Denmark, if you're a participant in the system, you have a primary care doctor. And in fact, your primary care doctors can have a panel of up to 2,500 people enrolled in their panel. They get paid on the basis of that, and then they can collect fees for patients that aren't on their panel. You have a primary care doctor. You get sick in the middle of the night, and it's not his night on. You can go on the internet or on the phone, and you will talk to a primary care doctor, 24/7 coverage. You explain your problem, and because of their data system, you tell them, you give him a key, and he can open up your record, and you can say, well, you had this problem and this problem. I think that you ought to go to the emergency room now. And when you get to the emergency room, your record is there, and the referral is there. Or he might say, take 2 aspirin, call your doctor in the morning. In the morning, when your doctor gets there, in his email is a complete report of that interaction between you and the on-call doctor. And you own the record, not the government. And the government doesn't keep the records. The records are in a private nonprofit corporation that's independent of the government itself. So they've protected the records, they've made the records the property of the patient, and they've tied them to the emergency room, the hospital, the doctor's office, and the pharmacy. Because if he had said, you need an antibiotic at 3 o'clock in the morning, he would tell you what pharmacy to go to, and the prescription would be there electronically waiting for you. So there are things to learn about how we manage, and these are part of the administrative cost, to go back to that point about administrative costs. And the other interesting thing, my last point on this, is that 3.5% that Medicare, you know who actually administers that? They aren't government employees. It's under contract to the insurance industry. They can manage Medicare for 3.5%, and they do.
Okay, the last prepared question, and this is one that I found interesting this week because there does appear to be consensus politically on this particular point, and that's the issue about insurance for people with pre-existing conditions. That, however, ties into another thing, which is the question about whether people will have to have insurance. It is extremely popular to talk about the one end of it. Everybody gets insurance, even with pre-existing conditions. The mandatory insurance, whether you particularly want to pay for it or not, that's another side to the whole issue. So I was going to ask Don to talk about this.
Well, to state my answer to the question, I think yes, that insurance companies should pay for pre-existing conditions. But with that said, with an economist to my right, I look at it also from the insurers who are the insurance companies, is that their main concern, and here we are getting into my true opinion here, is that their main concern are the shareholders. I mean, true enough, we want you to get good health care as a, you know, if I'm a CEO of a United Healthcare or Blue Cross Alliance or whoever it may be. But I have a true obligation to the shareholders. $93 billion. It was only surpassed by, what, the oil company last year, a couple of the oil companies. And, I mean, that's a lot of money, $93 billion. And so if these people insure people with pre-existing conditions, then you have to understand that the bottom line is going to go down. Because the bet is that the chances are is that you're going to need the health care more than a person who's just out here that, you know, working out every day, eating well, and maybe going to the doctor once a year for a checkup. You're going to need it more so than them. But once again, I think that, yeah, the pre-existing conditions should be covered, because the thing about it is, if we're going to be a country, is that we're going to say, I'm going to borrow a line from the education, no person left behind, then we really need to do that. Because the people that, you know, it's the sick that need a physician, not the healthy.
I agree with Donald. I mean, the same thing as the CEO of an organization when it comes to pre-existing conditions. You know, employees come on board and you look at it, for example, we're self-insured, and if somebody comes on with a pre-existing condition that could be, say, a liver transplant or something on that line, for example, if we hire that individual and they go in and go and get their liver transplant, that'll cost me about $500,000 that basically goes straight to my bottom line, because we're self-insured. So what that does is that affects the whole stability of the organization as a whole. So sometimes you got to look at that just as a business line. Now, a lot of people say, well, that's the insurance company, but most large organizations are all self-insured. So that, you know, a lot of these insurance companies are also just a third-party payer where we pay them administrative fees to administer the policy and all that. So we're all hit with this in a way for this pre-existing condition that it ends up affecting the whole organization. Larger organizations can absorb a lot of these medical conditions and pre-existing conditions as where some can't. For us, yes, we could probably to a level, but if I were to be hit with a number of pre-existing conditions that we were to bring on board and then take the big hit for it, that could basically wipe us into a negative financial condition that then we couldn't provide services for our community. So it's huge. The insurance companies are, and this is, I'll throw my opinion, insurance companies are not our friends, especially hospitals and individuals. They're very much out to make sure that they don't have to pay the hospitals or make life hard for patients. And, you know, that's where we get into, that's why people have really got hard on pre-existing conditions, that overall we don't want to deal with it because we know it could be a large cost to the organization. I believe that we should be. Luckily, I don't have any pre-existing conditions. I've been able to change, go to different organizations over time, but it does impact, especially if you have a family member. If I would have had a family member, I might have not been able to accept this position and bring this organization to the next level because I would have to stay where I was at. So it's a double-edged sword right now.
Let's go back again. I guess because I'm the oldest on the panel, I have all these historical perspectives. I lived through all of this stuff 3 or 4 times. But there was a time in the 60s and 70s when Blue Cross was a major force. It was a nonprofit organization, and it did community rating. Everybody that enrolled in Blue Cross essentially got the same premium. That leveled out the difference between the person with pre-existing conditions and the 25 people who are healthy and don't use much in the system, but they're paying into the system, and it's got a community rating. When the indemnity insurance companies came into the business, they came in and they said, hey, Mr. Employer, we can give you a better deal, and we'll just insure your people that are really healthy, but they'll get a lower premium. Blue Cross resisted that for a while, and then they had to convert, and they had to give up on that and start doing medical underwriting, which is what pre-existing conditions is all about, looking at each individual and saying they've had this problem, that problem, therefore their rate's going to be this higher, we're not going to fund them, cover them at all. You mentioned something that hasn't come up yet, and that is the individual mandate. Right. Yeah, and the individual mandate that Mr. Obama is talking about, in my view, is a way of backdooring community rating. Because if you say that everybody has to have insurance, that means that the low-risk people, the young people who are unlikely to have anything except a major traumatic event, but they're not going to have the kinds of chronic illnesses that we're concerned about, those people will be paying into the system because it's mandated that they pay in, and that will offset some of the pre-existing condition loss that the insurance companies might have. So the individual mandate, insurance companies love it. I mean, that's part of this that they really like, because they look at that and they see 47 million new enrollees. Now, if you look at Massachusetts, which has been down this road now for 3 years, 97% of Massachusetts residents are insured now. They have an individual mandate. You either buy insurance or you get a tax hit. You get a tax hit in your state taxes. But it's got a 97% coverage. That's pretty impressive. And I don't think, it's going to take the country, if we go to that system, a long time to get 97%, but it's a lot better than having 60% covered under their employment.
I was just going to echo the point that was made that it simply isn't efficient when you can't have people move around from job to job or place to place. And when you're locked into a job, if you have cancer, then you won't be able to quit your job and move other places. One thing about Massachusetts, though, is my favorite economist on the subject, Paul Krugman, noted that, but he also noted that the subsidies for the young people and the people that were of low income weren't really sufficient, and he really didn't regard the Massachusetts system as a very good system.
The fine for an employer who doesn't provide insurance in Massachusetts is so low that it's not really an economic incentive to provide insurance. And similarly, the tax hit on the individual who doesn't take the individual mandate is so low that it doesn't really force them it's not as powerful as it could be from an economic perspective. So there are things to learn from Massachusetts.
But again, what I'm worried about is with all the costs going on the employer, that makes us not as competitive worldwide. And that is something we don't think about. I mean, the rest of the world is, if you said the phrase export or die, the rest of the world understands that. We don't. And we have been going on 33 or 34 now years importing more than we export, and jobs are leaving. So just having all that burden on the employer is a real problem. And just to bring back jobs, we're going to have to address that. Now, maybe reducing the cost for businesses will help. I personally think the single payer system that Canada has is a more efficient way of doing it, but I'm worried about the trade deficit. I think that is something that isn't talked about enough and needs to be addressed at some point.
I'm on your left. You see that, don't you? I think that, that's exactly right. The trade deficit is a huge problem. Healthcare is contributing to it. We had a study done by another economist. If you don't like what you hear from the first one, you always hire another one. It's like lawyers. But we had a study done by Kenneth Thorpe at Emory University, and we asked him the question, how much are we spending in Missouri on medical care? Nice straight question. He's a modeler. And he modeled it all and got every dollar that he could identify and came back and said $30 billion a year in this state. And so we said, well, that's interesting. At that point, we had 500,000 uninsured, and we said, how much more would it cost to cover the uninsured in the state? And he came back and he said, 1.2 billion, less than you're spending now. Less than you're spending now. And what did he do? Single payer. He did Medicare for all on the state level. And the interesting thing about it was, large employers would be paying less in payroll tax than they're paying in premiums under his system. Small employers who are not paying anything now would be paying payroll tax that they're not paying now. But so there are a lot of different ways to balance this back and forth, but there's enough money in the system, that big number that we've got, to take care of everybody if we did it smarter.
I talked to my doctor about this and asked him, who would you rather deal with, Medicare or the insurance companies? And he said, Medicare, no doubt, because for one thing, I wouldn't have to hire all the people I have to do all the administrative costs. Plus, the rules don't change. He realizes what the rules are and what is expected of him, whereas every year with the insurance companies, he says the rules change. So that's just that perspective.
I was going to open the floor to some questions then, and give you an opportunity if you want to talk right into the microphone so that we can record what your question is.
Dr. Kimming, I'm for the left than the left that you are from Dr. Watson. So I'm far left, I guess. We're a union family.
Hold the microphone next to you.
We're a union family, and proud and very fortunate. I'm retired, 71 years old, had a couple of heart events in 94, whatever. I wrote 114 words, of which 4 I stole from the Constitution, the preamble to the Constitution. I stole them, I plagiarized them. Promote the general welfare. I don't give a rat's ass how you do it. You have to share health care with everybody. And anybody says no, it's terrible. They're ingenuous, they've got their own. My wife and I have the best health care you can get. We pay absolutely nothing. Medicine, co-pays, operations, etc., etc. We are the most fortunate. But I don't want to be the only one in this room or any room that has this when other people don't have anything. It's unmerciful. But I wrote 114 words. I said 4 of those I stole from the preamble to the Constitution, promote the general welfare. The next 110 are my own. I'm a retired Union Boston, Massachusetts electrician from the Irish section of Boston, yes. In the early 60s, when I was apprentice and all us young guys, at contract time, for the first time, when we got our raises, we started a health and welfare fund. And all the young men, and the older men too, but I was so proud of the young apprentices. We all vote, in fact, we shut it down, some of the older guys. We want to put half that money to start a health and welfare. Not that we needed it. Altruism. We cared about unionism and about human beings. And it paid off for me, I want to tell you. Let's see. So we voted half our pay raises, we give it up to create our present union health and welfare system. What was then altruistic on my part and our part has become a health care benefit for my wife and I. We are the most fortunate. We pay nothing. No co-pays. I've already been through that. We are so fortunate. I want everyone to have health care. Tax my health care to help others. That I'd be damn proud to do. I want to contribute to the general health welfare. And I don't have any money. I'm very modest income, so it's not like I'm rich. As an aside, in 1970, skiing in New Hampshire, I compounded my left leg, cut my muscles, tendons off. 30 days in the hospital cost me $3,100. Didn't cost me $3,100 for the hospital stay for 30 days. $3,100 altogether. Well, then, what are they, $3,000 now? But that's about it, I guess. But another thing, I refused health care for my heart, and I don't recommend this to anybody. I refuse to have stents. If I have a heart event or if I get to the hospital, absolutely no stents. Balloon me. Well, you might die, Mr. Fish. I'm gonna die. I will not take Plavix, for example. A multi-million-dollar promotion. Everything you could ever look at is this $9 aspirin, in effect. So I'm lucky. I want everybody to have health care. Damn it, we got to fight to get it.
Okay. You have a question?
I do have a comment, but I'll try to be quick on it, and I do have a question. I'll pick up a little bit on what he said. Life, liberty, and pursuit of happiness is health care as far as I'm concerned. And I'll have to disagree a little bit with our CEO, Mr. Ford. I actually do want government in my life because I like the fact of the public option with more choices. And you look around in this room, I think it's disgraceful that we don't have more people here, especially from the hospital. We're the largest employer in Jefferson County. We're the only hospital. And I think it's a measure of how serious one is when people would rather try to retract a certified election and attack Obama rather than focus on the reform of things. And I'm also concerned if we don't have reform, and I'm really keying in on reform, I do want health care, but reform. If we have an epidemic, you have that trickle-down effect. If we don't have something in place now, it's going to be ugly. And Dr. Booker had said, you had said something about the ward system, and Jefferson Memorial has never had a ward system. I started working the first time in 1967, and they had semi-private rooms. So I pride that little hospital at the time that they had the two-room system as we know it. Now, lastly, with the question, I would like to ask the panel, what part does the AMA, American Medical Association, endorse of the president's plan, and what do you have to say about Kaiser Permanente? Used to hear a lot about that, and could you explain that to people who do not know that California system? Thank you.
Okay, a couple of meaty questions. I know the AMA has very tentatively backed the Obama plan. And again, I think that was one of the most interesting things about having Senator McCaskill here. She explained there's 5 different plans in Congress right now. And the speech that Obama gave last week does not directly connect to any of the 5 plans that are in operation. So try to talk about the healthcare reform plan or Obama's plan is very hard to do because this is constantly morphing and there's all sorts of versions of it. But does anybody know the AMA's position other than vaguely support it?
With a lot of the physicians I deal with, most do not promote the current plan the way it is. The AMA, basically a lot of them have now, have actually sent a resignation in the AMA, especially a lot on our staff. And I've heard that throughout the United States as a whole for physicians. And I think where it got crossed is it's kind of like with the American Hospital Association. We are very much in tune to having health reform and working together as a whole. The issue is they haven't promoted the current plan from Obama that has been in. And basically the way it has been formatted and the way I've read it, I can't endorse it either when it comes to a lot of different aspects of it. But there is some good parts into it, and that's where we need to go. And I think that's where a lot of the issues that came and a lot of the interfighting and the fighting between physicians, hospitals, and other people coming into it is, unfortunately, the government has came out and said, well, these areas promote this plan, and that's not totally true as a whole. They have came out and said we promote health reform. And I think that's what has got the American Medical Association upset about it is all physicians want it because it's all going to affect them too, because if we don't get some type of health reform, they're going to take a large reduction in any type of reimbursement in the next year. And it will be, basically most of the physicians I've talked to, if that goes into effect, if they're close to retirement age, they will, then we're going to have another major shortage of physicians as it is. The American Hospital Association put out a plan to promote and threw out a lot of dollar savings. I promoted, and yes, no, they didn't come and ask every hospital CEO in the United States, but they put together a plan. It's not a bad plan for it. And that's what we had promoted back to the government, is that we promote providing these type of savings to the United States healthcare system. So that's where I think a lot of the misinformation communication has came from, where a lot of people said, wait a minute, we're not promoting this bill, we're promoting health reform. And that's where the AMA and also the American Hospital Association, a lot of the other, we definitely are for health reform, but not in the current plan that they had sitting out there this summer.
You know, just a comment. As this is played out, I think of the Hippocratic Oath, which, you know, starts off by saying, first do no harm. And what am I seeing in terms of national politics? First, do no harm to the insurance industry, to hospitals the way that we operate now, to medical practice the way it is now. We've got to get past it. Everyone's going to get hurt in this. If it's going to work, something that everyone wants is not going to make it. And if we can't get to compromise, and I think the president's dead right on that, he may not be able to get a political compromise, but there's got to be compromise among the parties that are funding the opposition to this, either funding it with dollars or funding it with talk. And if we can't get a compromise there, again, we're not going to go anywhere.
I know some things about Kaiser. I wasn't quite clear on what, because that's a big topic. That's a very old health plan in California. So I think there's interesting things to draw from that model as well, but that would take a really long time to get into. Yeah.
Dr. Lloyd, I know your hospital very well. I can tell you that my husband is a VA person, somebody who gets the best socialized medicine, and they saved his life 2 years ago. The VA sent him to St. John's Heart Hospital, and he got a quadruple bypass. This last year, I hauled him over to the hospital where Festus residents because he chopped his hand up in his wood-turning device. And he's a VA patient, but you guys treated him there, and it was all good. I myself spent some time there this year, which is going to give, I have another story. My husband is covered by VA, but I myself ended my COBRA stint on August the 31st. So I've spent the last number of months since I have been retired, staying home taking care of my husband, trying to find other insurance. And I've been turned down because I have high blood pressure. And also because I'm 62 years old, I'm convinced of it. You don't get to be my age without having something wrong with you. So consequently, now I'm without insurance. And I spent overnight at your hospital when my blood pressure took a serious spike, and they thought it was a heart problem, and the good cardiologist there kept me overnight, ran me through a battery of tests, every test available, found out I have the heart of a 35-year-old, but guess what? The insurance company doesn't look at that. Doesn't look that I walk every day, that I'm a vegetarian, and that I'm in very good health other than that. They just looked that I spent the night in the hospital. So I may not get insurance until I qualify for Medicare. But that's my comment about that. But here's my question. It has to do with the economics of this. I had you in economics, by the way, and you gave me an A, so I like him. I did earn an A. That was tough for me. And it's about how this whole reform is going to be funded. Personally, I'm for a single payer or public option, whatever, because I feel like they're going to force an individual mandate to please the insurance companies, and I don't know how people like several of my sons who are carpenters will afford the insurance if they force it upon them without a public option or without single payer. But here's my deal, and I'm like this gentleman over here. I'm willing to pay more taxes so that other people can have taxes. And don't you think they're going to have to be honest at some point? They're all going to have to be honest and say, everybody's taxes are going to have to be raised to pay. They really will. And I think we all ought to be willing to do that. Don't you think they will have to raise taxes?
Are you actually asking if politicians will be honest with us?
No, I'm saying that right now, President Obama is saying people under, over a certain limit will be taxed more, which
Right.
I agree.
But the average person will not receive increase, yeah.
I believe like you, I think all of us should be willing to pay a bit more so that all of us can have insurance.
One way I look at it is, what's the difference if your health costs go up and your premiums go up or your taxes go up? It doesn't make any difference. It's still money out of pocket. But again, what I'm worried about is that we're becoming not competitive. We're losing our manufacturing base and putting that burden totally on employers. And that is the real best argument, I think, for a single payer system. And we're continually losing a lot of jobs because of it, and Jefferson County has suffered from that.
Anybody else want to take a stab at that?
I agree. I don't think there's any other way to pay some of the shortfalls without raising, if we go to, honestly, in my mind, I'd rather have one single payer on a certain day. Because right now, I spend so much money between Medicare, the insurance companies. For example, just alone, working with the insurance companies and Medicare and Medicaid and all that, I probably spend about a quarter of our salaries just doing that paperwork and billing for what we need to do. It's incredible. And right now our payroll hits up close to the $60 million, and I spend close to 10 to 15 to $20 million just in labor costs taking care of that. So one payer system would be great as a whole. To get to that I think we're gonna have to raise taxes and be honest about it, because there's no way that we're gonna currently do it with the funding systems that we have, or we're just gonna, keep printing money, and then in the long run with the economists here, you're gonna see what happens when we start printing money. It's gonna come back to haunt our kids in the next 10 years.
If you could raise, just so we can get a couple more in, please try to put this in the form of a question, to borrow from Mr. Trebek.
I would like to ask a question about illegal immigrants that I think has kind of been taken off the table. I've seen that maybe there's 12 million in the country, and I've heard maybe that 4 million don't have health care. Since they're in the food processing and services industry, has there been anything written about the economic impact of not covering these people, given the fact that we have problems like tuberculosis, hepatitis, and the impending pandemic that has been recognized? It seems ludicrous to exclude people that are working and in the public so dynamically.
You made my case. I mean, you're dead right. It's a public health issue.
Okay.
Yeah, I mean, there's nothing to add to that. The people that are really out of sorts about undocumented workers, and let's, illegal aliens sound like they have big eyes and they're sort of green, and that suits the people who are doing that. And this Lou Dobbs sees them as big green eyes. These are undocumented workers. Second word, workers. They're doing something. They're working. And yet we're saying these people are working, but because they're not documented, we'll let them be a reservoir of infection. That's nuts. That's really nuts. But politically, that's where it's going to have to stay. I mean, there's no way, you heard what happened at the president's speech, and then I went on with Charlie Brennan on KMOX, and, all Charlie wanted to talk about was illegal aliens. And he has this wonderful construction about how the Obama approach to care is going to lead to more care for illegal aliens. Good.
Right on.
I had a couple questions. You have a question, please?
Yes, to make this a question, I'll address the panel who is very informed on healthcare issues. There is a proven way to reduce American healthcare costs 50%. And my question is going to be, are you at all aware of the following? In 3 major studies, one the Department of Defense, one Medicare, and one private insurance, people who saw medical doctors and also saw chiropractors had healthcare costs in the Department of Defense study 48% lower than those who did not. In the Medicare study, 59% below those who did not. And in the private insurance, it was Blue Cross in Chicago, and Dr. Kemi talked about primary care physicians. Chiropractors were the gatekeepers in an HMO, and also later medical doctors who did not practice conventional medicine as their primary method. Costs went down 70% because drug use went down 85, hospitalization, went down 60, and certain outpatient procedures went down 65%. So, and that is a study published in a refereed journal. So my question is, has that been a secret, or are you aware of any of those studies?
Am I supposed to ask if you're a chiropractor? Okay.
I retired last week.
Okay. Would anybody like to address chiropractic?
Actually, I truly believe in alternative medicine also when it comes to a lot of different aspects. And chiropractic, the problem is what you run into, and you probably have too, is that the medical AMA and that have put a stop to a lot of those different areas of where we can get into that. And then also society as a whole want to see a medical doctor, or they wait till the last minute. I mean, I bring the example back is that unfortunately we are human beings. You're a human being, I'm a human being, my MDs are human beings, but we expect them never to make a mistake. And that's some of the issues, and then drug seeking has become another issue when it comes to that. Everybody wants to go, and we see that on a daily basis, come in our ER seeking, prescription drugs and everything else. But yeah, I have seen those studies. I've actually instituted having some alternative medicine coming in, but it's our society as a whole that's not accepting some of those areas. And if you were to go fully and do some of those areas, then you start putting yourself into the liability issues, is that I didn't treat this patient with the appropriate medical direction, and then guess what happens? We get sued. But I'm totally for that, and I believe that if we were to put the primary cares in place, we're actually trying to do that right now, is to create a larger primary care base within our county so people have access to that care, and actually even quicker care when it comes to that, so we can get those. I don't want people to be hospitalized. I don't want them to come to our ER if we don't have to, because that actually increases cost for everybody, and it's not about the money as a whole. It's the good quality we can, and I'd like to get to that way, and why I'm more on the alternative medicine. My wife loves that stuff, and she never gets sick, and she tries to push on me. Sometimes I'm in between on those areas, and the same thing is I've allowed some of those come in the hospital and give seminars, and it's what you'll hear from the MDs a lot of times is that's foo-foo. Let them come in, but that's foo-foo. But I've seen some people cured in the cancer world by doing alternative medicine, and their cancer is gone. And I sat and talked to a educator for college back in Indiana. She was on her last breath, and she was doing the alternative medicine, and I'm going, man, you should do something else. Guess what? She's still living today, and that's been almost 15 years ago. So it's pretty amazing, and I think some comes back into the mind and everything else together. But those are great studies, and I wish we could endorse some of those more and have the backing to do that.
On that, and you are a chiropractor, am I correct? Okay. I have a couple of friends that are chiropractors, and I've read those studies also. Unfortunately, as Dr. Ford was saying, and I'm using different words here, is that it's not the person who speaks the most truth, it's the person who speaks the loudest. And the AMA speaks the loudest in this country, let's be for real. And so, a lot of times people say that advertising and everything doesn't affect them, but it does. The lobbying and what you see come across the television and all other media affects, what we're willing to put into are the monies. And like Dr. Ford was saying, it's actually a lot of times it's the people. It's not necessarily anyone else. It's that we have to take the bull by the horns and do something about it. Because if the studies are there and it equates this, then why aren't we doing it? Why aren't people, driving on the interstate when the speed limit is 55 and they're doing 65? I don't know.
The other thing with this alternative is nurse practitioners and PAs. We can actually lower costs very much when it comes to our ER care and then out in rural America and even primary care. The problem is, for example, I'll get a phone call, a complaint saying I didn't see the physician. And it's a little bit more blunt than that when it's on the phone to me. But they don't want to see the nurse practitioner. They don't want to see the PA for the cold and everything else. So that's when all of a sudden you go from, a visit of $75 to $350. That's the biggest difference. And right now we're in the process of trying to develop a couple of those clinics that can take care of those care. Kind of like when they say the Walmart or the Walgreens concept in it, that we can have some of these clinics around here. Now, it's not going to take care of the extreme cases and all that, but be able to take care of these and lower that healthcare cost because, we can employ PAs and nurse practitioners at about a quarter of the cost of a physician. We got to change. I mean, a lot of people have endorsed it. Rural America is very much endorsing it, but when you come into here, sometimes it becomes marketability is, I want to be able to continue to keep those patients in our area, but all of a sudden they figure that they're getting inferior care because they're not seeing an MD or a DO. What do you have to do to be able to keep that? But I think as we continually educate people and show them, I think there are going to be more and more that are going to kind of endorse that type of care here for the future.
Germany's system, I'm not sure if they cover chiropractic, but I know they used to have coverage in their insurance system for massage therapists, and their percent that they spend on GDP as a healthcare as a percent of GDP is lower, 8 or 9%. According to the World Health Organization, their outcomes are better. So
Spas are covered by their insurance plan. I'm just gonna.
No, you're not, unless you can wrestle me for the microphone. Let me just. I'm the physician on the panel. I've got to respond to all of this.
Okay.
I think that where the change is going to come in the acceptability of alternative medicines from the medical schools, who are now teaching courses in alternative medicine, and who are working with Logan, the local medical schools in St. Louis. That's very different. I went to medical school, University of Wisconsin, and was taught that your profession is, somewhere next to used car salesman. But there were none of those studies at that point in time. But what I did figure out, and I think I figured out, was that the people I was seeing who were coming into that university hospital, who'd been seeing chiropractors, and there have been a lot of chiropractors in Wisconsin, were doing pretty well. And why they were doing pretty well was because someone was spending time with them and touching them. Spending time with them and touching them. And the physicians don't do that. And I think that, and I think the same goes for nurse practitioners and goes for physician's assistants. These are people who take time in a way that physicians don't. And we got to fix that too. So, the alternative medicine, it's there, it's coming, it should be covered by insurance. And a lot of people get better because of it.
No, thank you. Just one more question. I'll let you have the last one. I know. It's not. Maybe it's the same question.
My question refers to something that you said, Dr. Kimmy, but I would like some response from the panel in general. Dr. Kimmy, you said that every solution causes a problem. In your mind, what problem would be caused by the public plan? What problems? I'm referring to a comment that you made. But in general, I would like to know how the panel feels about a public plan. I have been very involved in Missouri for single payer for a number of years, and so I've kind of, trying to be more, come to more middle of the road and say, okay, I'll not, hold my breath for single payer. We'll get another kind of public plan. Now it vacillates from one day to the next, whether Obama really wants a public plan. Oh, it looks like maybe it's going to be this co-op thing. And, I'm still, holding out for something as close to single payer as it gets. But what problems would be caused by a public plan? And asking that in response to
Big thing that I see with another public plan, especially in the hospital and the physician, is you're adding another layer that we got to deal with and negotiate. If you're going to do a single public plan, then let's wrap Medicare, Medicaid, and put this public plan in one form. Then we got to deal with one and the insurance companies. Right now, all you're doing with this new public plan is adding another one in there. Another problem for us that I'm going to have to add additional staff and everything else. It's kind of like the new RAC audits that are coming out in the United States that CMS didn't want, but our Congress mandated. I have now just had to hire one person that just coordinates the paperwork back to the government when they ask for the charge. So what it does is it's going to increase, in my mind right now, if they add another payer in there, it's going to increase our cost by labor, and then additional people to try to continue to negotiate with them. And so my feeling on that is if we're going to do a public option, let's all wrap it into one so we don't have to deal with all these other areas. And that's where that would be a single payer, except for then the biggest issue you're gonna have to deal with now is Wall Street and insurance companies. And that's the other big problem. If you get most insurance companies now are all on the Wall Street, and then what you're gonna do is the problem you're gonna exist is now you're gonna take away people's investments in these insurance companies. So how are we gonna deal with that? How are we gonna pay all these people that have investments or own stock within all these insurance companies? I mean, for example, United Healthcare is worth probably $200 billion right now. How are you going to distribute that money back out? And they're going to be asking their shareholders for the government to pay. So there's another problem right there that so there's kind of escalating domino effect with going to a single payer at this moment. which I think we could get to over a long period of time. But in the long run, you know, somebody's going to have to pay for it. And that, I think that's our biggest issue, and the problem is somebody's going to have to pay for it, and they're going to have to mandate it. Is it going to come out of our pockets or out of the, ultimately it's going to come out of ours somehow. And so let's just be honest about it and set it up and then move forward and get through it. And we're all going to have to sacrifice in the long run.
Well, I can't let that one pass. No, I think in terms of causing problems, the president of Anthem Blue Cross Blue Shield, about 6 weeks ago, said a public option, according to our studies, would enroll 130 million people virtually overnight, and that would drive us out of business. That's 40% of the population. If 40% of the population wants a public option, why shouldn't they have it? And who is Angela Braille to say they can't have it? So, you know, I think there's a real issue out there. It would cause pain for the insurance industry. It would cause pain for the stockholders. But I had a sneaking suspicion just yesterday that maybe the insurance companies were owned by the Arabs. So I went, well, a lot of things are. So we went and looked up and the top 10 beneficial owners of the insurance industry. We looked at United, we looked at Anthem, we looked at Aetna, a couple of the others. Unfortunately, it isn't true. So I can't say the Arabs are owning insurance companies. But the English own a big chunk of all three of those. Barclays Bank is one of the big holders in all three of them. But most of the owners of those companies are Fidelity and other investment firms. These are not small investors. These are big corporate investors. Going to the stock market is a risk, okay? They've benefited from the risk, and if their risk doesn't pay off, tough stuff.
I'm going to wind it down here because we're running out of time. I wanted to thank you so much for coming this evening. I can't imagine how I could have had a better panel than this. Maybe if we had somebody from the insurance company who would defend that position. But I'm very pleased with the level of expertise and the amount of information you're able to provide.